Next, we're going to talk about hypoglycemia and hypocalcemia. So hypoglycemia is usually defined as blood glucose levels less than 45 milligrams per deciliter. So you'll read that between 40 and 50 is the normal lower limits. So 45 is probably the number you want to memorize. Hypoglycemia is, like we said, defined as glucose levels less than 45 milligrams per deciliter. You want to measure the glucose level on all infants that are considered at risk. Those infants would be less than 34 weeks, SGA, LGA, if their mom has diabetes, if they're late preterm, or had a difficult birth. Signs and symptoms of hypoglycemia include jitteriness, lethargy, poor feeding, an abnormal cry, hypotonia, temperature instability, respiratory distress, apnea, and seizures if it gets too low. Hopefully we don't get that far. And the way to treat it is to feed the infant and repeat the test. Repeat the glucose test in an hour. And if that's not sufficient, that doesn't bring it up, then you want to start IV therapy. Hypocalcemia is serum calcium levels less than 7.8 to 8 milligrams per deciliter in term infants and slightly lower, about 7 milligrams per deciliter in preterm infants. Risk factors for hypocalcemia include ill neonates, if the mom has diabetes, difficult birth, low birth weight, preterm, or if mom is treated with any anticonvulsants. It's usually early onset and occurs between 24 and 48 hours after birth. Signs and symptoms include jitteriness, high-pitched cry, irritability, apnea, cyanosis, abdominal distension, and laryngospasm, or they can be completely asymptomatic. So to treat hypocalcemia, you can, if the mom is breastfeeding, you can fortify her milk, or if it's a formula baby, they can take preterm infant formula, which has higher levels of calcium in it. And I think one thing your book noted that if you treated the baby for hypoglycemia and the baby is still jittery, then you probably want to go ahead and treat them for hypocalcemia, because sometimes they can go together. So we're going to talk about the laboratory and diagnostic testing that is kind of universal and highly recommended, and most states are mandated. So first is the universal newborn screening, and this is a blood test. In the hospital, because this test started out just measuring a few blood disorders, and one of them was called PKU, so you'll hear in the clinical setting a lot of times they'll just refer to this as the PKU test, but it tests for much more than that. So it's mandated by U.S. law, and you're looking for early detection of genetic diseases that result in severe health problems if they're not treated early. So on page 575 in your book, and here on this slide, it shows the form that you fill out and the circles of blood that you fill up. So you do a heel stick, and the blood is placed on this special filter paper. You want to obtain it after the baby is 24 hours old and before discharge, so really at 25 hours of age, anytime after the baby turns 24 hours, it is accurate. And the sooner these are recognized, the better, so it's best to go ahead and get it at 25 hours versus 48 or 72 hours. It screens for 31 core disorders and 26 secondary disorders. So next is the newborn hearing screen. And if you look on page 576 in your book, there's 2 different types of hearing screens that are being done there. All newborns, it's recommended that all newborns receive a hearing screening before discharge, and there's 2 types. The EOAE is the initial screening, and then the ABR is a follow-up. It's also a screening, but it screens. It's a little more sensitive and would be a follow-up if the infant fails, or what you'll hear is refer. They referred on their left, or they referred on their right ear, or they referred on both ears. We use the word refer instead of failed their hearing screen. But some hospitals have the ABR as their routine equipment. Newborns should be identified for hearing loss because early intervention is very important to their developmental outcomes. And the final screening is CCHD, so screening for critical congenital heart disease. And the way this is done is simply a pulse ox to detect hypoxia at 24 to 48 hours of age. You want to measure the pulse ox on their right hand and then one of their feet. You want it greater than 95%, and if there's a difference of more than 3% between the hand and the foot, that would be concerning. So you want both of them to read greater than 35%, but you don't want the difference to be greater than 3%. So really, in the hearing screen, you can do right away, but it's best to let some of the vernix dry out in their ears. So really, it's best to do all of these tests right at 25 hours of age. So as far as collection of specimens, if you look on page 577 in your book, there's figure 24-12 and 24-13. The heel stick is by far the most common way that you get blood from babies. So with the heel stick, you want to warm the heel for 5 to 10 minutes, wear gloves, clean the foot with whatever solution the hospital requires. Then you poke their foot with a little lancet. The puncture should be on the outer aspect of the heel and not penetrate more than 2.5 millimeters deep, and that's the lancets, the blade is not longer than that. That prevents that. And it's important to minimize pain with non-pharmacologic techniques such as non-nutritive sucking. So you can dip a pacifier in sucrose, you can swaddle the baby, but pain control is very important. Next is venipuncture, and so venipuncture would be used if you need a larger sample of blood, or if you were doing blood cultures. You use a butterfly needle with the tourniquet, and again, you want to minimize the pain with non-pharmacologic techniques. Final is the urine specimen, and this is usually collected with a little urine collection bag that either goes over the penis or kind of cups around the vagina to catch the urine before it goes in the diaper. These interventions are just real straightforward and just more of an FYI. These are different interventions. First one is the protective environment, and so these are recommendations of the American Academy of Pediatrics, Joint Commission, and OSHA, and just all the regulatory bodies. The environmental factors include adequate lighting, decrease in any type of fire hazards, making sure their electricity is safe, all the electrical outlets are safe, and the temperature is adequately controlled. And the final is infection control factors, and recommendations are to position cribs 3 feet apart, and excellent hand hygiene, wearing gloves, and making sure visitors wash their hands. So those interventions are nothing that you need to memorize, but it is covered in your book. Next, we're going to talk about preventing infant abduction and newborn falls. So you have seen in your clinical settings the different ways that infant abductions are prevented. So most units are locked and you have to ring a bell to get in. Most units, the OB staff wear certain color scrubs, or their ID badges have a certain picture or certain color on it that nobody else in the hospital has. The infant wears 2 bracelets, one on their wrist, one on their ankle, and those match the mom. And you want to make sure you match those bracelets each time you take the baby to the mom, no matter if you've been taking care of them for an entire shift or up to 3 days. And the most important thing for preventing infant abductions is parent education on the protective mechanisms that each facility has in place. So to prevent newborn falls, most falls occur when the mother is asleep holding the newborn. There's a risk of head injury if an infant falls and hits the floor. Infant falls are typically underreported by parents because they're embarrassed. The nurse can help decrease newborn falls by identifying maternal risk factors such as medications that would make a mom drowsy. It's important that the infant always sleep on their back in a bassinet, and infants are always transported in their bassinet. They should never be carried around the unit. They should always be pushed around in their bassinet. Here's a picture of an infant security system. This one's called the HUG system, and so this has a bracelet on mom also called KISS. So this is kind of a neat infant security system that when the infant's foot bracelet gets close to the mom's bracelet, it gives you a real pleasant sound that they match, and it would give you a not pleasant sound if they didn't match. And so this helps prevent babies being taken to the wrong mother. And then the band on the infant's foot, if it got anywhere near any kind of exit doors, it would set off the infant security alarm and lock the doors. So this is just one electronic infant security system.